Okay, let's unpack this. There's so much our skin tells us. Think about it. Every little mark, every subtle change, that nagging itch, they can all be vital clues, like a secret language our body uses to communicate its inner workings. Sometimes the messages are incredibly surprising.
Oh, definitely. What's fascinating here is just how much information our skin truly conveys, acting as really a dynamic window into our overall health. It's often the first place our body shows us something's amiss.
Absolutely. And today we're embarking on a deep dive into some of the most commonly encountered dermatologic disorders. Our compass for this journey is a foundational text. Chapter 5. Commonly Encountered Dermatologic Disorders from the Fitzgerald FNP 2024 workbook. It's a pretty comprehensive guide, and we're going to help you extract the absolute essence from it.
Yeah, our mission for you, our listener, is basically to give you a true shortcut to being well-informed about skin conditions. We're going from the foundational principles of how to assess skin and speak its precise language, all the way to recognizing key conditions and understanding their treatments.
Ultimately, we want to equip you with the ability to interpret those subtle skin clues, to make sense of what might appear on yourself or others, and most crucially, to know when it's really important to seek further care. It's about becoming a detective of your own skin, really. So let's dive in. So when we talk about assessing skin, it's easy to just focus on the visible problem area, right? The rash, the spot. But our source highlights a really important principle. In dermatology, you should always assess the entire patient, not just the isolated skin problem. It's rarely just skin deep.
That's a crucial point. It's all about context. The workbook lays out key clinical considerations. For example, a primary question is the patient otherwise well? If they are, no fever, no unexplained fatigue, no systemic symptoms, then the condition is very likely limited to the skin itself. We'd think of things like rosacea, which causes that facial redness, or maybe keratosis pilaris, those small, rough bumps often on the arms, or even seborrheic dermatitis, which most people know as dandruff or cradle cap.
Okay. But what if someone comes in and they're just miserable?
Mm-hmm.
They don't have a fever, maybe, but they're clearly suffering.
Then you ask, is the patient miserable but not systemically ill? This means the discomfort is intense, often a lot of itch, burning, or pain, but without those wider signs like fever or loss of appetite. Conditions like scabies, which causes that intense itching,
Oh, yeah?
or herpes zoster, shingles, fit this description perfectly. They're localized, but can make someone truly deeply uncomfortable.
And then there's the most serious scenario. Is the patient systemically ill with constitutional signs and symptoms? Now, when we say constitutional signs and symptoms, we're talking about general body symptoms that affect your whole system. Things like fever, unexplained fatigue, loss of appetite, unintended weight loss, or general malaise, that just feeling of being unwell.
Exactly. In these cases, the skin problem is often a significant clue, a manifestation of a broader systemic disease affecting the whole body. Classic examples include varicella or chickenpox, which has that distinct rash along with fever. Or more severe conditions like Lyme disease, which can present with a characteristic rash. Or even systemic lupus erythematosus, an autoimmune disease that can affect many organ systems, including the skin.
Okay, here's where it gets really interesting, I think. How patient demographics and other risk factors play a surprisingly big role in diagnosis. Our source points out that two facial conditions, acne and rosacea, can present with similar-looking lesions. But you'd be looking for them in different age groups, right? Acne vulgaris is typically seen in teens and young adults, while rosacea usually appears in adults aged, 30 to 60?
That's right. And beyond demographics, understanding the risk of transmission or contagion is vital. Psoriasis vulgaris, for instance, has absolutely zero contagion risk. It's an inflammatory condition, not an infection.
Okay.
But impetigo, which looks like those crusty sores, is a bacterial infection, and it absolutely carries a contagion risk, especially, among kids.
Which brings us to another powerful diagnostic tool, understanding how skin lesions evolve, like how they change over time.
This raises an important question for any skin detective, as you put it. Are there only primary lesions, meaning the direct results of the disease process, or are there primary and secondary lesions? Secondary lesions are changes that happen to the original lesion, maybe through scratching or just time. Knowing what the oldest and newest lesions look like and when they appeared allows us to truly assess the progression. It's like watching a story unfold on the skin.
Speaking of reading the skin's story, there's an important principle from our source. Learning the specific language of dermatology is absolutely critical. It's like unlocking a secret code just for what you see on the skin.
It really is. We distinguish between primary lesions, which are the initial unaltered manifestations of a disease. They haven't been scratched, treated, or changed by time yet. A classic example is a vesicle. That's a small, fluid-filled blister less than a centimeter across.
Uh-huh.
You'd see these in conditions like chickenpox or herpes zoster.
And then we have secondary lesions, which are those that have been altered somehow.
Exactly. These are changes to the primary lesion due to outside factors like scratching, treatment, or just the natural course of the disease. So when that fluid-filled vesicle ruptures, the dried serum and blood remnants that form on top become a crust. That's a perfect example of a secondary lesion.
Okay, let's bring this language to life. Maybe with a few key examples from our source, imagining what a patient might say.
Sure. So if a patient mentions a spot on my cheek that's been there for years and it's flat, just a discoloration, irregularly shaped, maybe half a centimeter, that's what we call a macule. It's simply a change in color, not texture. You can't feel it.
Or they might say, that mole on my shoulder hasn't changed in years. If it's a single, uniformly brown, slightly raised, irregularly shaped spot, say 6 millimeters, what's that?
That sounds like a papule. It's palpable, meaning you can feel it when you run your finger over it.
Okay, and imagine someone saying, a smelly liquid leaks out of this when I push on the area. Yikes.
Yeah, that paints a picture. That describes a cyst, usually a single, firm, smooth, raised, dome-shaped lesion that's encapsulated and fluid-filled beneath the skin.
Memorable,
Right.
Definitely.
Or how about, for the past couple of months, the skin between my toes and on the bottom of my feet has been itchy and cracked.
That's a classic fissure. It's a linear crack with sharp walls, basically splitting the skin, common with things like athlete's foot.
Okay, and if a patient, maybe undergoing chemotherapy, says, these purple splotches appeared on my arms and legs, and you see flat, non-blanchable, purple-colored, irregular lesions blending together.
That's purpura, and non-blanchable is key. It means when you press on it, the color doesn't temporarily disappear like it would with simple redness.
And finally, a really common one. This itchy rash appeared all over my body a few hours after starting my antibiotic. If you see clustered, smooth, slightly raised, circumscribed, itchy, skin-colored lesions, maybe different sizes, often surrounded by redness, that's a wheal. Think hives. Classic allergic reaction presentation. Now, beyond individual lesion types, the pattern or distribution of lesions across the body provides incredibly crucial diagnostic clues. It's like the skin is telling a spatial story, indicating how the problem might have originated or spread.
It really is. For example, linear lesions appearing in streaks. That pattern is a huge hint, isn't it? Think of phytodermatitis like poison ivy, poison oak, or sumac. You'll often see those distinctive streaks of fluid-filled blisters, the vesicular lesions, hours after exposure to that urushiol plant oil. It's almost like you can see where the plant brushed across the skin.
Exactly. Then there are clustered lesions. These occur in a tight group but without a specific defined pattern, like a line. A common example is the cluster of vesicles you see during a herpes simplex type 1 outbreak, a cold sore.
Okay. And if the lesions are scattered?
That means they're generalized over the body without any specific pattern or obvious distribution logic. We often see this with viral exanthems, those widespread rashes caused by viruses like rubella, for instance.
And confluent or coalescent? That sounds like things are merging.
That's precisely it. Multiple individual lesions are blending together, forming larger continuous areas. You often see this with the thick, scaly plaques in severe psoriasis vulgaris, where patches of skin merge into one another.
And a very distinct pattern, often a major diagnostic giveaway, is annular.
Right. Annular means the lesions form a ring, often with the center clearing up as the ring expands. The characteristic bullseye lesion in Lyme disease is the perfect, unmistakable example of an annular lesion.
You know, it's a powerful insight from our source that the majority of dermatologic conditions are actually diagnosed clinically. What that means is, for most skin problems, you don't necessarily need a biopsy or complicated lab tests, right? It's often about gathering key risk factors, listening carefully to the patient's history, and doing a thorough physical exam. Your eyes and hands are kind of your primary tools.
That's absolutely true for the vast majority of common conditions. However, and this is important, there are crucial instances where additional testing, like a biopsy, is absolutely necessary. It might be to confirm a diagnosis or, more critically, to rule out something serious. Our source gives a compelling example. A painless ulcerated lesion, maybe 1.5 centimeters on the neck, that's been there for weeks, especially in someone with significant sun exposure, like a landscaper. That kind of persistent, unexplained lesion raises immediate suspicion and usually requires a biopsy. It often points towards a basal cell carcinoma.
So that need for a biopsy immediately makes me think, okay, what about more serious concerns like skin cancer? What should we really be looking for?
Well, there are several key types of skin lesions to be aware of, sort of moving along a spectrum from precancerous to cancerous. First, actinic keratosis, or AK. This is considered precancerous. These typically appear on sun-exposed skin, think face, scalp, back of hands. They look like red, brown, or flesh-tone scaly patches. They can be tender, but usually they don't cause many symptoms. Now, while they might stay the same or even go away on their own, they do have the potential to progress to invasive squamous cell carcinoma. So intervention is important.
And what kinds of interventions are usually considered for those AKs?
Our source discusses a couple of approaches. There's pharmacotherapy, basically, topical creams that can treat them, like 5-fluorouracil or imiquimod, or there are tissue destruction methods like cryosurgery, which is freezing the lesion, or maybe laser resurfacing or a chemical peel. Often a healthcare provider can diagnose it clinically just by looking and feeling, but sometimes a biopsy is needed for confirmation.
Okay. Then we have basal cell carcinoma, BCC, and squamous cell carcinoma, SCC. These are actual skin cancers. What are the key differences a listener should know?
Right, both BCC and SCC require a biopsy and usually excision for diagnosis and treatment. Basal cell carcinoma, BCC, is the most common type of skin cancer by far.
Okay.
It usually appears on sun-exposed areas and often arises de novo, meaning it starts fresh, not usually from a pre-existing mole. It might look like a pearly or waxy bump or nodule, sometimes with a little central dip or erosion. Often has pretty distinct borders, and you might see tiny visible blood vessels called telangiectasias. The good news, relatively speaking, is that its risk of spreading to other parts of the body metastasizing is low, but it can cause significant local tissue destruction if it's left untreated.
And SCC, squamous cell carcinoma.
Squamous cell carcinoma, SCC, is less common than BCC, also typically found on sun-exposed areas. SCC can arise from those precancerous actinic keratoses we just talked about, or it can also start de novo. It often presents as a red, hard lesion that might be kind of conical in shape, sometimes with ulceration, and its borders are often less distinct than BCC. SCC carries a greater risk of metastasis spreading, typically estimated between 3% to 7%. That risk is highest if the lesion is on the lip, inside the mouth, or on the genitals. So like BCC, it needs removal, but there's a bit more urgency regarding potential spread.
And finally, the one that often generates the most concern, malignant melanoma. How do we recognize that one, and what's the immediate action?
Yeah, for malignant melanoma, we rely heavily on the ABCDE mnemonic. It's incredibly effective. Studies show high sensitivity and specificity when 2 or more features are present.
So, okay, let's break that down. A.
A stands for asymmetry. One half of the mole or lesion doesn't mirror the other half.
B.
B for borders. They're irregular, often notched, blurred, or scalloped rather than smooth and round.
C.
C for color. The color isn't uniform. You might see multiple shades of brown, black, tan, or even patches of red, blue, or white within the same lesion.
D.
D for diameter. Usually the lesion is 6 millimeters or greater at its widest point, about the size of a pencil eraser, though they can certainly be smaller. E for evolving. This is perhaps the most crucial sign. It means any change in a long-standing mole or pigmented lesion, change in size, shape, color, elevation, or new symptoms like itching, crusting, or bleeding, or just a brand new lesion appearing, especially if it looks different from other moles. Sometimes people include elevated here too.
So if you see any of those.
Any suspicious lesion fitting those ABCDE criteria always requires prompt evaluation and usually a biopsy, often an excisional biopsy, to confirm the diagnosis and determine the depth. Early detection is key with melanoma.
Okay, now that we've covered how to approach diagnosis and some of the more serious concerns, let's pivot back to some of the very common dermatologic conditions you might encounter day to day. Let's talk classic presentations and typical treatments. Our source outlines some great examples. Let's start with eczema. You know, that often recurring history of dry, scaly skin, intense itching, maybe crusted or weeping sores, and it typically gets worse in cold, dry weather. You often see it in the bends of the elbows or behind the knees. For that, a common first approach is often a medium-potency topical corticosteroid cream.
Exactly. Then there's rosacea. This might present as someone having, for months, facial redness, maybe some swelling, small pus-filled bumps, or pustular lesions, particularly over the nose and cheeks. often with visible little blood vessels, those telangiectasias again. For this, a common treatment is a topical antibiotic like metronidazole, usually in a cream or gel.
And scabies, that sounds intensely unpleasant.
Oh, it is. It typically causes an acute onset of intensely itchy red bumps, papules, and those characteristic burrows, which are tiny, raised, squiggly lines in the skin, often worst over the wrists, between the fingers, and the armpits. This requires a specific scabicide treatment, like permethrin lotion applied head to toe.
Okay. What about pityriasis rosea? That one sounds less familiar.
It's quite distinctive, actually. It often begins with a single, larger, salmon-colored oval patch on the trunk. We call that the Herald patch. It gets bigger for a bit. Then, usually a week or two later, smaller, similar oval lesions appear, mainly over the chest, abdomen, and back, often in a pattern that people describe as looking like a Christmas tree distribution along the skin lines. It usually resolves on its own over several weeks.
Interesting. We also often see verruca vulgaris, common warts, right? Our source mentions a potential treatment like imiquimod cream.
Yes, imiquimod is an immune response modifier that can be used for certain warts, particularly genital warts, but sometimes others too. There are many wart treatments, though freezing, salicylic acid, etc.
Right. And for tinea pedis, athlete's foot, that icky, cracked, sometimes peeling skin between the toes or on the soles.
For athlete's foot, a common treatment is a topical antifungal cream, like ketoconazole or clotrimazole. Good foot hygiene is key too, of course. Now, a really fascinating condition that highlights that skin-systemic health connection is acanthosis nigricans. This presents as dark, thickened, hyperpigmented plaques. They have a sort of velvet-like texture. You most commonly find them at the nape of the neck, in the armpits, or groin folds. Patients often report having these since adolescence, and they typically don't cause any itch or pain.
And our source makes a very important connection about this condition, linking it to something else.
Yes, exactly. With acanthosis nigricans, it's a crucial insight that you should really consider checking a hemoglobin A1C level. This skin finding is strongly associated with insulin resistance and can be a visible marker for underlying type 2 diabetes or prediabetes. It's a perfect example of how the skin can act as a signpost for what's going on inside the body. It's also important to note the typical locations: neck folds, axillae, armpits, groin folds, sometimes over knuckles or elbows, but you don't typically find it on the plantar surface, the bottom of the feet. That specific location helps differentiate it.
Okay, now let's talk about something incredibly common, especially if you spend any time outdoors. Contact dermatitis from plants like poison ivy, oak, or sumac. Our source gives a scenario with Anna, a 22-year-old landscaper. She's had intense itching and lesions on her hands, arms, and right cheek for about 4 days.
Right. So when you anticipate the typical findings for Anna's phytodermatitis, which is caused by that plant oil called urushiol, you definitely expect to see those fluid-filled blisters, the vesicles. And where they've maybe ruptured or been scratched, you'd see crusts. Critically, you would also likely find many lesions in a linear pattern because the oil gets spread in streaks as the plant brushes against the skin or she scratches.
Makes sense.
What you would not expect, based on her presentation of just being miserable with a rash, is fever and generalized malaise. She's systemically well, just really uncomfortable.
So what does this all mean for treatment? Let's say Anna's rash is pretty widespread, affecting maybe 20% of her total body surface area. What's the best approach then?
Okay, our source provides clear guidelines here. For localized, less severe acute contact dermatitis, topical treatments are usually fine, often mid or even high-potency topical corticosteroids. For thinner skin areas like the face or eyelids, you'd want to use a lower-potency corticosteroid to reduce side effect risk. Ointments are often preferred over creams because they provide more of a barrier and keep the medication on the skin longer.
But you have to be careful with the stronger ones.
Yeah, definitely. There's a risk of skin thinning or atrophy with prolonged use generally. We think more than 2 to 3 weeks continuously, especially of the higher potency topical corticosteroids.
And what if it's more widespread, like Anna's case with 20% body surface area affected, or really severe?
That's when you move to systemic treatment. Systemic corticosteroids, like oral prednisone, are preferred when 20% or more of the body surface area is involved. Or if the rash is particularly severe, maybe with lots of large blisters, or if it significantly impacts sensitive areas like the face, genitals, or hands, or even if it interferes with someone's job.
How long would she need to take that?
The recommended duration for prednisone in these cases is typically 10 to 14 days total. Often it started at a higher dose, maybe 0.5 to 1 milligram per kilogram per day for the first 5-7 days to get it under control quickly. Then the dose is usually reduced by about half for another 5-7 days to prevent the rash from flaring back up as you stop the steroid.
And you don't need a long taper after that.
For these shorter courses, typically 14 days or less, an additional gradual taper beyond that initial reduction isn't usually necessary.
Okay, and just for relief from that awful itch and discomfort, what other things can help? Adjunctive therapies.
Yeah, simple things can make a big difference. Cool compresses can feel really soothing. Calamine lotion or colloidal oatmeal baths can help dry out oozing lesions and calm the skin. Over-the-counter pain relievers like ibuprofen or acetaminophen can help with any discomfort. And oral antihistamines like diphenhydramine or cetirizine are usually very helpful for managing that intense itching, especially at night. All right, moving on to bacterial skin infections. Our source covers several common ones that are important to recognize. Let's start with impetigo nombilis. This is the most common form. You'll typically see a flat red spot, an erythematous macule, that quickly evolves into a small blister, vesicle, or pus-filled bump, pustule. These then rupture really easily, leaving that classic sticky golden or honey-colored crust.
Right, I see pictures of that. What causes it?
The main culprits are bacteria, Staphylococcus aureus and Streptococcus pyogenes. Often, a topical antibiotic ointment like mupirocin is enough to treat it. But if it's very extensive or if the topical treatment isn't working, then systemic oral antibiotics are needed.
Then there's impetigo bullous, which sounds a bit more dramatic.
It definitely looks different. This type involves a bulla, which is a larger, flaccid blister, bigger than a centimeter. It contains clear or maybe yellow fluid initially, which then turns cloudy or darker yellow. These bulla rupture easily too, usually within 1 to 3 days, leaving a red, moist base with a kind of shiny, brown lacquered or scalded skin appearance, sometimes with a rim of scale around it.
Where do you usually see that?
This type is most common in infants and younger children, and because it tends to be more widespread, it usually requires systemic antibiotics right from the start.
Okay. And what about cellulitis? That's a term many people have probably heard.
Yeah, cellulitis is an infection that goes deeper into the skin layers, the dermis, and the subcutaneous fat beneath it. It typically presents with localized heat, redness that tends to spread, and significant discomfort or tenderness. The borders are usually indistinct. A more superficial form of cellulitis, often on the face, arms, or legs, is called erysipelas. That one tends to have very sharp, raised, well-demarcated borders.
And the bacteria involved.
The most common causative organisms are Streptococcus pyogenes, group A strep, and less commonly Staphylococcus aureus, including both MSSA, the methicillin-sensitive kind, and MRSA, the methicillin-resistant kind. Systemic antibiotic therapy is always essential for treating cellulitis to prevent it from spreading further.
And finally, a cutaneous abscess. What's that?
An abscess is basically a localized collection of pus within the skin. It often involves a hair follicle and the surrounding tissue. Like cellulitis, it usually presents with heat, redness, and discomfort or pain, but the key feature is that it forms a fluctuant or tender mass filled with pus.
Caused by.
Staphylococcus aureus is the main causative organism here as well. Both MRSA and MSSA are common. Treatment varies depending on the size and location, but it often involves incision and drainage of the pus, sometimes in addition to antibiotics.
So when we're thinking about antibiotics for these types of common skin infections, impetigo, cellulitis, abscess as our source gives us a general guideline for how long treatment usually lasts.
Yes, it mentions that the general recommended length of antimicrobial therapy for many common uncomplicated skin and soft tissue infections treated in the primary care setting is typically around 5 to 7 days. Of course, that can vary based on the specific infection, severity, and patient factors.
Wow. We've covered so much ground today. From really understanding the subtle language of bumps and spots, the descriptions and patterns, to knowing when a seemingly simple rash might actually be telling a much bigger story about systemic health or when it needs urgent attention. It truly shows how our skin serves as this dynamic map, almost like a personal narrative about our health.
Absolutely. If we connect this to the bigger picture, it's really about shifting from simply seeing skin changes to truly understanding their potential significance and what actions might need to be taken. This deep dive has hopefully armed you with a solid framework to be a more informed observer of your own skin and maybe that of your loved ones too. And this raises an important question for you, thinking ahead.
Considering the incredible diversity of skin conditions we explored today, from the common to the concerning, how might a deeper understanding of your own family's dermatological history, what skin conditions tend to run in your family, influence your approach to skincare and monitoring for yourself and your loved ones in the future? Something to reflect on, perhaps, as you consider what stood out most to you from this deep dive.